The following Agios-supported podcast is intended for informational and educational purposes only and is not intended as medical advice. Please speak with your healthcare professional before making any treatment decisions. The guests on today's show were paid to participate in this podcast.
Welcome back to Just Listen, Voices of PK Deficiency. I'm your host, Dr. Rachael Grace.
I'm excited to introduce our guest for today's podcast, Dr. Eduard van Beers, an international expert in rare anemias, including pyruvate kinase deficiency. Dr. van Beers is an adult hematologist and researcher at the University Medical Center Utrecht. Dr. van Beers leads cutting-edge research in multi-center clinical trials at his center and within the European Reference Network for Rare Hematologic Diseases, EuroBloodNet. He is a key member of the steering committee for the PEAK registry and committee for published international pyruvate kinase deficiency guidelines. Dr. van Beers, welcome to today's podcast.
Thank you so much, Dr. Grace.
Before we get started on today's topic, Dr. van Beers, tell us a little bit about your focus in rare anemias and what led to your clinical and research interest in pyruvate kinase deficiency in particular.
First, I started treating patients with sickle cell disease, and I did my PhD thesis on sickle cell disease in Amsterdam, and then I moved for 1 year to the NIH in the USA. After that, I moved to Utrecht, so my current position, and there's a great tradition in rare anemia diagnostics, especially focusing on red cell enzyme disorders. And I run into what was a new disease for me at that moment. It was pyruvate kinase deficiency. And I was really very interested in those patients because they had a lot of the problems I recognized from sickle cell disease, except for those painful crises. And then I wondered why nobody was caring for them and why nobody was looking into the problems my sickle cell patients had, such as osteoporosis and also iron overload, which is not very common in sickle cell disease, but it's more common in thalassemia. So I just tried to do all those clinical studies in these patients because I thought they should have these problems. And then actually I met you because you were leading the natural history study at that time. And together we learned much more about the need of these patients. And I learned so much from them. Their stories, what happened in their child age, because I see adult patients and what happened when they went to study and how they work and all their problems. And well, I tried just to make their life a little bit better because for me, quality of life is key in how I treat patients.
Thank you so much for sharing that. Our topic for today is about transfusions in people with pyruvate kinase deficiency. And one way that we sometimes talk about transfusions in different red cell disorders is by defining patients as being regularly transfused or not regularly transfused. And I wonder if you think this differentiation is helpful in the clinical care of individuals with pyruvate kinase deficiency.
This is a very interesting question. And I think it is helpful because obviously the planning of clinical visits of patients on regular transfusion is much more often, and they use more resources from the hospital, and you've organized more screening for iron overload, etc. But I also want to stress that patients who are not on transfusion need also carefully monitoring of organ damage and quality of life as those on transfusion. Obviously, sometimes it's a little bit different, but at least you have to screen everything which you are also screening in patients on transfusion. But yes, there is a difference, but many patients on non-transfusions, when they're young, they can transition to transfusion dependent at any moment in their life.
Agios is a biopharmaceutical company that's fueled by connections with patient communities, professionals, partners, and each other. Building on these connections and the company's unmatched leadership in the field of cellular metabolism, Agios is pioneering therapies of genetically defined diseases, a broad group of rare and more common diseases that are typically severe and life-threatening. Near term, Agios is focusing on advancing a clinical pipeline of medicines for hereditary hemolytic anemias. To learn more about PK deficiency, visit knowpkdeficiency.com. That's knowpkdeficiency.com.
In your practice, when and why are regular transfusions initiated?
It's not an easy question because I think it's really patient dependent, depending on what kind of problems they have. It's dependent on their quality of life and also how active they are. I have had patients who had a perfect quality of life just sitting on the couch. And I just found out when I asked, what are you doing all day? And she said to me, I'm only sitting on the couch, not doing anything because I can't do anything else, but I'm happy. And then obviously we had a discussion what her wishes were and what else she wanted. And then there's no real need to start transfusion because she was happy with that and there was no organ damage. But I also had patients who got children, a job, and life was getting tougher and tougher when they aged. And their hemoglobin was the same when they were 20. But when they were 40, they needed transfusion while the disease was stable and they needed extra energy. And it helped them out because when they found out that they were going up to grams per deciliter by transfusion, it really made a big difference for them because they never tried transfusion. So for me, it's really personalized medicine decision between the healthcare provider and the patients, giving the balance between what they need for energy, how much their body is able to produce, and also in the context, how much organ damage they have and what kind of organ damage it is.
I think for hematologists, sometimes that's hard to understand. I think from a patient perspective, it seems easier to understand because, as you're saying, it's how somebody feels and making a treatment plan based on how they feel. I think a lot of hematologists are more familiar with the management of thalassemia and thinking about set hemoglobin cutoffs for transfusions and thinking about that, applying that to other red cell disorders. How would you talk to another hematologist or patients who wonder about that set hemoglobin cutoff and thinking about transfusions?
I think this is, again, a very good question. Obviously, many hematologists are not familiar with PKD, and so it really helps to centralize the patients with one doctor. I think normally young patients with PKD are much more able to tolerate low hemoglobins as compared to thalassemias. But I found in my personal experience with the patients who come into my office, this changes when they age, when they get in their third or fourth decade. They start to need more transfusion support. And sometimes it starts out with one transfusion every 8 weeks and then less. What I would recommend, follow the guideline, screen for organ damage. If you find some, discuss with the patient how you can manage it. And if you think you should manage it with blood transfusion, discuss it. It's really about quality of life. And then you can ask if they get a random transfusion somewhere in their life, how did it work for them? How did they feel? And now if they don't know, you can do just one transfusion if they have some tough week ahead of them. For instance, sometimes I have younger patients who are still studying. And then if they have a week full exams, then sometimes I propose to try a transfusion. And then they can tell me how it worked. And if it worked out fantastic for them, and they know, then you're going into a talk about regular transfusion. Obviously, you also have to discuss the side effects of transfusion with the patient, such as, iron overload, a risk of blood-borne infections, and all the venous access problems you can run into if a patient has to come into your hospital regular for a blood transfusion.
For many patients, they're going to a hematology practice where they're the only person who has pyruvate kinase deficiency. Not everybody has access to a center, a reference center, as you said, a center with expertise in this area. And many hematologists haven't seen other patients who have pyruvate kinase deficiency. And you mentioned about the guidelines and what they say about transfusions. I wonder what advice you would give patients, people who have pyruvate kinase deficiency, about how to bring this conversation up with their hematologists, people who aren't being transfused but feel like their quality of life is being impacted by the anemia.
I think it's good to discuss what we say in the guidelines, that it's about quality of life, and they have to tell that their quality of life is not good and that they want improvement and that they maybe want to work more or be more in society, more able to do in their life than lying on a couch all day. So that's the first recommendation. And if this hematologist is not familiar or afraid to transfuse, they can, at least in many European countries, you could consult another expert via this European reference network for a kind of second opinion and advice on transfusions, I would advise not to sit down and contact a PKD expert in your country who can help to your local physician how to treat it. And that's also how I work in the Netherlands. Compared to the US, the Netherlands is more like a city than a country. But even I work with a lot of local hematologists who I do give advice about transfusion regimens in my patients.
In the US, it works differently, but there still is the possibility of getting a second opinion. For example, the hard part is that oftentimes people need to travel to see another provider to get that opinion in person, which is expensive. But I think if people are able to do it and aren't feeling like they're getting the care that they wished they had or that follows guidelines, then that's a potential way to meet with another hematologist with expertise in this area. You had mentioned about what the downsides of transfusions are a little bit. Could you talk more about that? What's involved for patients starting regular transfusions? What does that look like?
So I think there are a number of side effects. So for me, the two most important are, one is iron overload. Every bag of red cells you get about 200 to 250 milligrams of blood, depending on how much is in the bag actually. You build up iron and there's no normal way to excrete iron from the body. So you have to remove it with drugs which are called iron chelators. And normally you need about 2 to 3 to even 4 pills of iron chelators, such as the various forms which are available in your country. But most patients don't have a lot of side effects from that. And if you take them regularly, they always work in my experience. It's only a problem if you have side effects, and then sometimes you have some alternatives which you can use as well. So iron overload is really one of the most prominent medical side effects. I think from a patient perspective, the other problem is that you have to come in regularly to your hospital, and that transfusion care is really pretty expensive. So if you have to pay that out of pocket, it's really a lot. It means that some patients need to come in every 3 to 6 weeks to get a syringe and have to get a blood draw to get a match of donor cells you can receive. That takes 2 to 3 hours. You have to wait, and then you have to wait to get your blood transfused. So it will cost you normally 1 day, and 1 day once a year is not a problem, but 1 day every 3 weeks is a lot.
Some people who get transfusions regularly have access issues over time where it's difficult to place an IV to get the transfusions. How often do you see that as coming up as an issue in your regularly transfused patients, and what are some potential solutions for that?
I do see it. It's not as often as in other diseases in my experience, but if you have access problems, it can be really painful because it's very hard to get the syringe at the right place, and they have to try 3 or 4 times. And every time they try, again, make the risk of future access problems bigger. These days, what really helps is ultrasound-guided insertion of the syringe, and that also reduces venous access problems. But I like the Portacat solution, where you get a very small plastic box under your skin, where the nurses can really easily insert a syringe to inject you with blood. And sometimes it's a kind of those Portacats, those small plastic box, can stay in place for 10 to 15 years, but you have to be very strict with how to use it, and your personal hygiene has to be of high standards. It's easier because my patients are not growing anymore. And if you want to place a Portacat in a growing child, then it's more complex because the body is growing and this small plastic box is not growing.
I think the venous access issue really is a problem, or can be a problem, in the entire age continuum. Young children have small veins, so it can be difficult, especially if someone's at a center that's not used to placing IVs in young children or drawing blood in young children. Then they can get scarring, and it can become more and more difficult over time. But that also happens in adults too. So I think it's helpful for people to know what the options are in terms of making it potentially easier to get regular transfusions. I think what you mentioned at the beginning, really advocating for yourself in terms of what has worked well for placing the access, using an ultrasound for guidance, that people should feel that they can advocate for that before the first person's trying to place the IV so that things are less painful and easier in terms of trying to facilitate those every 3-week or every month kind of appointments.
Yeah, I totally agree.
You had mentioned at the beginning when we started talking about this a little bit about differences in management between people who are regularly transfused and people who aren't. What are some of those differences in terms of things that you might do for somebody who is regularly transfused or that you do for everybody?
I think in the end, I do the same for everybody because you need to check all the organ damages. And I think that we, together with the international PKD community, have stressed that even patients who never got a transfusion really need to be screened for iron overload. Having said that, treatment of iron overload in a patient who does not get regular transfusion, in my experience, is easier than in patients who get a regular transfusion because the amount of iron which is getting in the body per unit of time. So for instance, every year you get much more iron into your body when you get regular transfusions as compared when you don't get regular transfusions. So you need to screen every PKD patient. But if you have done your job and you find that a patient without transfusions doesn't have iron overload, then it's easier because you don't have to screen that often for iron-related complications, especially not if a never transfused patient does not have iron overload, you excluded iron-related organ damage, then I don't think you have to screen that often. In patients who have transfusion-dependent pyruvate kinase deficiency, you need to screen always for iron overload related complications. So endocrinopathies, osteoporosis, all those complications we have listed in the international guidelines, which are published in Lancet Hematology.
When you think about transfusions, you had mentioned a lot about the risk of iron overload and complications that can happen with buildup of transfusions and iron over time. How often do you see issues with actual transfusions and transfusion reactions in your patient population who has pyruvate kinase deficiency?
I'm very happy that you asked this question because I never see it. Because if you take your chelation, you will not run into iron overload problems, in my opinion. It's really easy to monitor. It's easy to treat if you have no side effects of iron chelation, which most of the patients don't have them. So then I think that transfusion is better than not transfusion if you really need it, because it prevents some other complications. At least that's what I think. I don't think we have very strong proof for this, but we have seen this in thalassemia. If patients really have low hemoglobins, a lot of hemolysis and a lot of complaints, they're often also medically better off with transfusions, potentially reducing the risk of osteoporosis, maybe pulmonary hypertension, hepatosplenomegaly, all these kinds of problems which are related to anemia, which we know are related to hemolysis, are all probably also reduced by transfusions in PKD as they are in so many other anemias.
I think there's a lot of emerging work about the impact of anemias and our management of them on quality of life and on the ability of people to conduct their usual lives or their hope for their usual lives in terms of school and jobs and activities and their families. And I wondered how you in your practice support people from a psychosocial perspective who are regularly transfused and also those who maybe you see less often who aren't regularly transfused who have pyruvate kinase deficiency.
I think that's important part of the disease, what happens with your social life, your education, your chances to get a job. For instance, jaundice. If you're very jaundiced and you go for a job, it doesn't help if you step in the bus every day and every day people ask whether you have cancer or any other kind of disease. No, it can be very tough. You can feel insecure and alone because of your disease for various reasons. And also, I think something like a burnout, it's much easier to get if you already have a disease where you have literally have a problem in your energy metabolism and you have less energy, then it's easier to walk in something such like a burnout. Obviously, this is no medical scientific proven fact, but that's what I experience in the many patients I have seen. Also because you're less able to go out or maintain social context because you need your rest, and makes that the chances of having social isolation are bigger. Many are not able to get a full-time job, and it's really hard to do something about that from a medical perspective, except for trying to increase their energy. For instance, by trying a transfusion program. But we have social workers in my department which can help patients to accept what it is, also how to divide the amount of energy they have and make decisions in their life. For instance, maybe work a little bit less, then they also earn less, but then they have more time to spend with family and social relations and have a happier life, because there's no real social security for those decisions. But it's important to discuss it, because otherwise they don't have any social life. And what also could help is ergotherapeutics, we call this. These are people who give you advice how to divide your energy through the day and how to do things more efficiently. And many of the advices of healthy life also apply, I think, for PKD patients. Some of the issues I often discuss is what you should do about sporting. And I always advise to try to keep a healthy life, which is also means active life, and try to train regularly. Because if you don't train, you will get deconditioned and you get more fatigued. And in my experience, patients who go out to the gym or do something other active, they get more energy instead of less, and are more able to maintain a good social work balance than other patients. It helps to discuss these issues with your patient from a medical perspective. So it means advising on healthy food, healthy habits, enough sleep, and also exercising. But it also helps to have social workers who can advise about work balance, and also maybe if there are any local, state, or country supporting programs for them to get the help, and also a psychiatry if needed, or ergotherapeutics, what I mean about how to build up your day.
You raised such important points. The recommendation for asking about psychosocial impacts of pyruvate kinase deficiency on everyday life is part of the international guidelines, and the recommendation to really support people and having, as you said, social work or somebody in a similar type of role checking in with patients and their families on a regular basis. I think that often happens in many places for people who are regularly transfused. It's sort of part of that practice. I think where we are often missing this is in people who aren't regularly transfused and are coming less often. And as you had given in the example before, may say, oh, I'm feeling fine, but actually, that they're on the couch and they're not doing everything. They're just doing what they're used to doing. So I think that we all need to make sure that we're providing those supports to everybody, regardless of how they're being managed, to check in. And I think with doing that too, it makes us revisit our treatment strategy too, to hear in detail what's going on with somebody in terms of their everyday life and the impacts. And I think as physicians, we don't ask about that. Sometimes there's a push for time and people get busy and then don't really get into the details of what everybody's everyday life looks like. And having a team approach to care helps to get all of that information to make sure that everybody's needs are understood and that we're doing our best to meet them.
If I can add to that, now I see it as a kind of slow hematology or something like that, because you're always thinking ahead about whether they can work, when, it's really long term. And what you do have slow impacts, just like iron overload. It's not something which targets you in 1 year. It's planning ahead and you have time to adjust it. And then it's easy, especially if you have also an hem-oncology practice and you're called because there's acute graft-versus-host disease. It's much easier to run to the second floor and treat your patients who are on transplant unit than take care of your PKD patient. But every time you see those patients once in 3 or 4 months, or even once in 6 months, you don't touch on this point, they will miss out another year of work, social interaction, or build up their iron overload and slowly building up organ damage. And you are thinking, oh, they're doing fine, they're doing fine, they're doing fine. So you have to really ask deeper in their lives, what they're doing. And just in a small example, another patient I had, she was also quite happy and She was rating her life 7 out of 10. No, it's okay. And then somehow I asked her what she was doing on work, and it was not a lot. And we're discussing, how did you feel when you got a transfusion? She said, oh, much better. And you want to try another one? And in the end, we started a regular transfusion program every 4 weeks in the end, because if she felt still drop back the few weeks before transfusion. Then after 3 years of transfusion therapy, I asked her how she rated her life. And she said, oh, doctor, I'm so happy. I still have some problems, but I have much more energy. I'm back to work. I have a job. I feel that I'm appreciated again. So I give my life a 7 out of 10. And I said, but you gave your life 7 out of 10 3 years ago. And said, no, it was a 2 out of 10. And that's the problem, because they don't know where they are and they don't know what they can achieve if they get more support.
Yeah, that is such a good point, that people acclimate to what they're used to and then don't necessarily know, as you're saying, how good they could feel if things were different. And so it's hard to evaluate how you feel if you've always felt that way. You had mentioned about exercise and the importance of that in terms of fatigue and ability to participate in other aspects of your everyday life. I wondered if you have certain guidance that you give people about their hemoglobin or degree of anemia and the types of exercise that you recommend, or if everybody can do all the types of exercise that they want to do.
I think that everybody should be able to exercise. Obviously, you have to listen to your body. So if you are doing too much and your heart rhythm goes above 180 in a few seconds, no, it's too much. But everybody should be able to do this. And if you are not able to do exercise because you're so short of breath, then we need to talk, because that's not what we want. And maybe we need to change something in how we manage your health. So if you're not able to do this, then there's something wrong and you have to discuss it. And if you are able to do it, but you don't do it, I recommend start doing it, because you will feel much more energized, because your muscle, your lungs, your heart, they get trained, and you can do more with the small amount of hemoglobin you have.
I completely agree. This comes up for children a lot, and a huge aspect for many children in their social life and well-being is participation in sports and being able to exercise and keep up with where you want to be with your peers in terms of those activities. And so finding the just right balance. But just as you're saying, if somebody isn't really able to do it because of the way that the anemia is impacting their body, then we need to rethink our treatment strategies. That our goal, as you had said at the beginning, is to have everybody have a good quality of life and to be able to do the things as much as possible that they want to do. This is, I think, exercise and sports participation in these types of activities have an importance at every age, really. And I think people get different advice from hematologists and different physicians that they see about the anemia and what they're able to participate in. And I found that the advice for many people is overly restrictive and has a significant impact on quality of life.
Yeah, I totally agree. And I don't agree with those advices. No, stay active. Activate, I would say.
When you talked earlier about hearing from your patients and making the decisions about transfusions, and you even said, let's try one transfusion and let's see how you feel afterwards. How do you evaluate the effect, or how do you ask people to evaluate the impact of the transfusion to see, is this providing benefit? Is this improving quality of life, for example?
In adults, normally, if you ask them, how does it feel the first few days after blood transfusion, they will easily tell you how it went. Because if they can't, then maybe they don't need it. Or there's something else really happening with them, why they are so fatigued. Many patients have other disabilities as well, especially when they age. For instance, if a patient has arthrosis with a lot of pain and you give additional transfusion, then they are still not able to be active. And they then find out that they're fatigued because they have so much pain on their joints. But normally, if you give one transfusion, a patient can easily tell how much clearer they can think, how much better they can walk the stairs, how much more energy they have around during the day. So they can tell you what is happening. And if not, then either there's another medical problem or they just don't need it. And then it's easy. So in my opinion, it's not that difficult. Just try it in patients who you would transfuse if they have thalassemia. Obviously, there needs to be something you want to treat. Either it's organ damage or it's quality of life. If both are good, you don't need to do a trial. But if there's something you feel you need to try out, then just try one transfusion and the patient can tell what's happening. And then if you then start doing regular transfusion, normally I ask, how's your general quality of life? Are you able to do? Are you working again? Or if they're not working, are you helping on the farm? Can you treat your children, etc.? And then I normally ask, how is the week before transfusion? And sometimes they say, then I can do anything. I just lie on the couch and I have a headache or feeling very fatigued. I can't read or whatever is their problem. And then I ask, do you want to cut this week out of your schedule? And if the answer is yes, I say, no, we go from every 5 weeks. We go to every 4 weeks of transfusion and you are rid of this really awful week and they're happy again.
That sounds like a great strategy. Do you find for payers that you need to show this in a more objective way, or is there something that you document around transfusions and the effect that helps to support, if there are payers for the transfusions, that it supports continuing that? I think that people sometimes run into the issue where there's a policy where they live that you can only transfuse for a certain hemoglobin, even though that's not what's recommended in the international guidelines, as we talked about. And if transfusions are given, sometimes there may be a need for an objective measure. And many things you're saying are objective. You couldn't work and now you can work. That seems very objective. But I wonder if for some of the more subjective things, like saying you feel better, if you have more objective ways of looking at that.
To be honest, I don't have this problem in my country, and I don't have really objective measures. You can obviously do quality of life. So I would recommend to do PROMIS or something like PROMIS fatigue or PROMIS, maybe even pain interference, because normally we say, oh, PKD, pyruvate kinase deficiency patients don't have pain, but I often hear that they have headaches the last week before transfusion or some other pains, back pains or anything like that. And some of my patients know they work 3 weeks and then they have 1 week off. Now, that's also very objective, as you already said. I think these kind of measures, or you could also try pyruvate kinase deficiency specific quality of life measure. I'm not sure if they are open to the public, but at least PROMIS is a very often used quality of life scheme.
Yeah, I think none of these are really used, I think, in most people's practices. I do think it would be really helpful to have easy measures that are objective, like those surveys, but as easy as possible for people to answer the questions and for the clinician to score them or evaluate them for a numerical value that is objective, to really show that there's an improvement with the treatment over time. And I think hopefully we'll get there, that we implement some of these in our practice. But I think most of us aren't quite there yet, and our measures are more complicated, which makes them hard to do in regular practice.
I do agree, but I think that there are now, especially in Europe at the moment, for sickle cell disease, we are starting to implement standardized quality of life measures, which will be rolled out to all other anemias as well, eventually, including pyruvate kinase deficiency, which is explicitly on our radar. And the good thing about PROMIS is that it's a generic measure and you can use it for other diseases as well. And that helps us to make the right decisions in healthcare. And then hopefully we will find that transfusing more in PKD is really helpful and also cost efficient, because people are able to work and contribute to society.
I'm interested in how you're going to introduce that into everyone's practice. I think that sounds inspiring in terms of really being more methodical, in terms of not just objectively showing how people are doing better with treatments or not doing better and changing the treatments, but also really having that consistency of asking the questions, I think, which is missing from a lot of people's practice, as we've been talking about, or people get busy and forget to ask about those very important questions. And just to clarify for people listening, PROMIS is a quality of life measure, a survey that asks specific questions with specific answer options about different symptoms people might be having or impacts of their symptoms on their everyday life, to try to get a sense of how pyruvate kinase deficiency or another anemia is having an impact on them.
And also adding to that, there are many forms of PROMIS, and you have some domains. You can ask something on fatigue or pain or physical functioning. And the trick we as experts have to do is that we ask the right questions, because If we ask to our patients, can you run the marathon, 41 kilometers? Nobody can do that probably. Some patients can do it. They train a lot, but most, that might not be the best question, but they need to be sensitive to our patients. So within this generic domain, we have to ask the right questions. And yes, also in Europe, we are very far from PKD patients being asked this every time they are in their office, but this is the plan we have in the European Reference Network. And also every European member state has a quality system for clinics that are able to treat pyruvate kinase deficiency patients. And we're getting more rules when you're allowed to treat these patients. And that will be including quality of life measures soon in the coming 5 years.
I think that's going to be so helpful in guiding treatments, is seeing, as we were saying at the beginning, about who maybe should be changing their transfusion strategies from as needed to regular transfusions, or thinking about other potential treatment options for pyruvate kinase deficiency. So that I look forward to hearing more about that as that's introduced into the clinical practice within Europe. Before we finish, I wondered if there were other aspects about pyruvate kinase deficiency or transfusions in pyruvate kinase deficiency that you wanted to mention.
Yes, I want just to continue what you just said, because we have still to learn so much. Also because we didn't record quality of life in our charts and we're still not doing it good enough. And then how you can explain to payers that something you have changed really improves quality of life and really improves patient going to work or having a better life. What is really key here is that we continue collaborating in registries, and not only in Europe, not only US, but we have to collaborate together, because it's so rare that we need every information from every patient to fight for them, to advocate for them, and also so they can advocate for themselves, because we have also one patient helping us in the steering board to guide us to the right scientific questions, but also to structure the registry in the right way. So I just would say, please help us and contribute to the register so we can improve your healthcare.
I completely agree with you. And one of the ways in which there's been so much progress in our understanding and the treatments for pyruvate kinase deficiency has been through registry data. And as you said, in a rare disease, this is the way to make progress, that we don't have the knowledge that we wish we did about the complications that people have with a condition, or how our standard treatments are working, or what complications people develop from those treatments, unless we collect that information. And I agree that it really takes partnership between all of the patients and all of the providers across the globe in a rare disorder to come together to gather that information and continue to gather it over time, so that we can continue to make progress and provide even more optimal care in our hematology practice. So I couldn't agree with you more about that.
Thanks.
Dr. Van Beers, we really enjoyed having you on the podcast today. Thank you so much for all your insights, and hope to have you again soon.
It was a pleasure to be here. Thank you so much, Dr. Grace.
We talked a lot on today's podcast about the importance of the international guidelines for pyruvate kinase deficiency, and wanted to make sure that you could easily find these and print them and bring them to your next hematology appointment. You can find these guidelines at pkdguidelines.org.
Thanks for listening to Just Listen, Voices of Pyruvate Kinase Deficiency. Don't forget to hit that follow button in your favorite podcast app so you don't miss an episode. Share the show with members of the PK deficiency community. And if you'd like to learn more about PK deficiency and see what resources there are to support people impacted by PK deficiency, visit knowpkdeficiency.com. That is knowpkdeficiency.com. Thanks for listening. I'm Dr. Rachael Grace, and we look forward to talking with you again.